Yeah, hi everyone. Hello and welcome to the FMG 2023 July recall of anesthesia. If anybody is live, they can just say hi. Otherwise, I'll start. And just like we expected, FMG session this time, this exam, this happened. It was pretty decent uh, with the changing dynamics of PG entrance exam. Looking on the similar lines, you now get a lot of technical questions, lot of questions with concepts in it rather than plain and simple, straightforward, fact-based questions. And this is just a continuation to that particular approach by the examiners. And what we saw is a lot of expected questions, but at the same time, they were not all very straightforward and very to the point of fact-based. Rather, they were all concept-based. And that is what we have been insisting always, that if you have a concept-based learning, then you will never fault no matter what type of exam comes. So hi Ravi, Sunil, Akshay. What we are going to do is we are going to discuss anesthesia questions, and there were a lot of anesthesia questions. In fact, there were integrated questions that can be dealt with anatomy, that can be dealt with surgery. So what we tend to do is we tend to sometimes over discuss them. So I will also discuss my aspect of things with you. But yes, you might find these questions with other specialties as well. The first one is a core anesthesia question. And this is something that we have discussed so many times. And while I tell you this topic, I always tend to tell you that in airway assessment, Malampatti classification is one of the most important things that you have to read. Because if there are 10 questions that come from the airway assessment, almost 7 questions are always from Malampatti classification. And that is exactly what they gave. They gave a picture like this. This is what all the students have told us. And then there were options that what is the scoring system in the image, ASA physical status classification, Malampatti, Cormack-Lihani and Brudsky classification. Now we know if we instruct the patient to open the mouth wide, protrude tongue with no phonation. That is the most important aspect of Malampatti. Open the mouth wide, protrude tongue with no phonation. This is called as Malampatti classification only when you look at the 4 structures, that is pillar, uvula, soft palate, hard palate. 4 intraoral structures, pillar, uvula, soft palate, hard palate. And based on this visualization of pillar, uvula, soft palate, hard palate, you have 4 classes, 1, 2, 3, 4, which is based on difficulty of intubation. Isn't it? Difficulty of intubation. Now, this is not something which is out of the book or out of the turn. It is very, very expected question of this topic. And so we know that the answer to this question is Malampatti. Now, just to quickly go through all the other options, ASA physical status classification is risk assessment. Now, it also has 6 classes, 1, 2, 3, 4, 5 and 6, depending on the increasing risk of complications associated with anesthesia and surgery. Cormack and Lihani is a direct laryngoscopic version of ASA physical status classification. When you want to visualize at structures on direct laryngoscopy, what are the 3 structures that we want to visualize? We see vocal cords. So from anterior to posterior, if we go, then we see epiglottis, vocal cords and posterior commissure. And based on what you see in these 3 on direct laryngoscopy, you have a classification called as Cormack and Lihani classification of direct laryngoscopy. Right? And last is Brudsky classification. This is something I think it is related to ENT, in which you go and look for tonsil. Grades of tonsil. Not very sure, but yes, that is something that you can look up. Okay? So this was first very straightforward, very easy question, that is Malampatti classification. Let's come to the next question. Again, very straightforward, expected question from core anesthesia. Following drugs are metabolized by Hoffman's elimination. Hoffman's elimination. Whenever we hear Hoffman's elimination, automatically the answer comes atracurium and cis atracurium. There is no doubt. And when we looked at the option of atracurium was there. It's a non-organ dependent metabolism, that is spontaneous degradation of the molecule under physiological pH and temperature. It is spontaneous degradation of the molecule under physiological pH and temperature. That is what is Hoffman's elimination. So the molecule automatically disintegrates. There is nothing that happens with the molecule. It automatically disintegrates. It automatically disintegrates. Okay. Now, if you look at metabolism of rocuronium, again something unique, no metabolism. No metabolism. It is only NDMR which shows no metabolism. It is excreted unchanged in urine, bile. So ultimately, its elimination is dependent on organs, while its metabolism doesn't happen, excreted unchanged. Vec and pan, metabolized by liver, straightforward, excreted renally. But let's look at a very important point, that atracurium has a dominant metabolism, dominantly metabolized by non-specific esterases. Non-specific esterases. 2/3 of the drug gets metabolized by Hoffman's elimination. Non-specific esterases. While 1/3 gets metabolized by Hoffman's elimination. 1/3 gets metabolized by Hoffman's elimination. All right. Everything okay with this? Everybody? If you guys are here, I can see there are 8 people. So you can just say hi. If you feel this was the question, fine. If you feel there is something else, you can always let me know in the chat box and we can have a discussion over that as well. Question number 3 is IV fluid of choice. I have got both the options, during surgery, after surgery. I don't know what is correct. Some people said sir during surgery likha tha, some said after surgery likha tha. But looking at the options, it doesn't make a difference. Crystalloid, colloid, blood FFP, that was the option. So normally when we say during the surgery, then we say it is maintenance fluid requirement or replacement fluid requirement, which also holds true after the surgery. But after the surgery, usually you don't replace, you replace when there is ongoing losses like intraoperatively. But this is not a very clear-cut distinction that okay, pre-operatively ye denge, post-operatively ye denge, aisa nahi hota. But we know that the maintenance or replacement fluid of choice for us is always a crystalloid. It is always a crystalloid. Now, what are crystalloids? Now, this is something that you get taught in detail in physiology, because acid-base balance depends on the intraoperative fluid, intravascular or in vivo fluid dynamics. And we know that fluid is intracellular fluid, extracellular fluid, and 2/3 of fluid is intracellular, 1/3 of fluid is extracellular. Extracellular fluid is then divided into plasma, intravascular, then interstitial, and intracellular fluid is then divided into multiple compartments. So we know a lot about fluid, and we know crystalloids, they are ionic water-based fluids. So they have ions and they have free water. Right? So they are ions. So they have certain ions and they are based with water. Water is the diluent in which you add certain ions, that is a crystalloid. And always the IV fluid of choice for maintenance is crystalloid. Now, Farheen is saying crystalloids tha hi nahi, bas normal saline tha. Okay. Let's assume that normal saline था. वैसे unlikely है because few students told me कि Ringer's lactate था. Are you sure? एक और एक्चुअली में पीडियाट्रिक क्वेश्चन भी आया था जिसमें फ्लूइड की बात हुई थी. One pediatric question also came, which I saw in somebody's recall that had something to do with a 3-year-old child. What would be the fluid of choice after, I think, diarrhea? Okay, so let's say it was normal saline. Then also crystalloid is the right answer. So you know whether it is normal saline or Ringer's lactate. But yes, normal saline is 0.9% in osmolality, which is little higher. Ringer's lactate has a plasma osmolality of 285 milliequivalents per liter, which is near plasma osmolarity. And that is why Ringer's lactate is considered to be most physiological fluid. It is considered to be most physiological fluid. Okay, RL wala malnutrition mein tha. Perfect. So I will edit it before this gets uploaded. I will make this crystalloid into normal saline, but the answer remains the same. Remember, blood is always for blood. Blood is for blood. So you replace blood with blood. That means when there is a blood loss, you want to replace blood with blood. You never give blood to somebody to replace the fluid. Remember this thing. Blood is for oxygen carrying capacity, because blood contains hemoglobin. Oxygen carrying capacity. FFP is always for coagulation. And intraoperatively, you will always hear FFP when there is severe liver dysfunction. And basically there is a coagulation problem. Then you give FFP. And colloids are fluids that contain large oncotic molecules. So it has a higher plasma or higher oncotic pressure. So they are usually used as resuscitative fluids. When you don't want to give too much of crystalloids, then you can use it as resuscitative fluids. So just remember basic. During the surgery, your replacement fluid of choice is always a crystalloid molecule, crystalloid fluid, rather than a colloid. Now in anesthesia, if somebody asks you, sir, what is the significance of colloid? What is the significance of colloid? So just tell them one thing. Colloids act as a prevention of spinal hypotension. The hypotension that happens after spinal. You can remember in anesthesia, if somebody asks you, sir, what is the use of a colloid? Tell them prevention of spinal hypotension. Prevention of spinal hypotension. Okay. Next question number 4. Which of the following is not a part of the ACLS protocol? Straightforward question. One question from CPR is always expected. ACLS is advanced cardiac life support. What is the difference between BLS and ACLS? ACLS is performed by a team of trained medics or paramedics. So they know what they are doing, and they always arrive in a scenario where cardiac arrest has happened. So their idea is to identify the rhythm and to manage it. That is what they do. Identify the rhythm and manage it. So we know that whenever an ACLS team comes, they will start with the CPR. They will attach the monitor, analyze the rhythm. If rhythm is shockable, they will shock. The shock is defibrillation. In ACLS, defibrillation is by a manual defibrillator. Then after some time, somebody will start taking an IV line. Once they have an IV line, then we use the drug of choice in CPR, that is adrenaline. Dose 1 milligram. Dilution 1 in 10,000. Number of doses infinite. You can give as many as you want. As many as you want. There is no upper limit to the number of doses of adrenaline. While second drug of choice in CPR now is amiodarone and lignocaine. Remember, both are second drug of choice. Both are second drug of choice. Amiodarone and lignocaine, but they both are only given in 2 doses. 2 doses only. Remember this thing, 2 doses only. Then comes soda bicarb. Now, soda bicarb as a drug in CPR was performed probably before 2003, considering the concept was that sluggish circulation will promote anaerobic metabolism. Anaerobic metabolism will produce lactic acidosis, and to counter this acidosis you will give soda bicarb. That was the original concept, but this has now been abandoned because no mortality benefit. Even if you gave soda bicarb for the acidosis, that is because of the sluggish circulation, there is no mortality benefit. Okay? So the correct answer to this question was soda bicarb. Correct answer to this question was soda bicarb. It's not a part of ACLS protocol. Right? Next is Taffirs line corresponds to which level? Now this is, if you see it this way, it's a pure anatomy question. It's a surface anatomy question, but I am dealing it because Taffirs line is the surface landmark for spinal anesthesia. It is a surface landmark for spinal anesthesia. And remember, Taffirs line corresponds to L4, L5 or body of L4. What does this mean is that when you palpate the Taffirs line, so what you do, you join the highest points of iliac crest. Now remember, there are 3 things in the ilium bone. One is anterior superior iliac spine, that you can palpate here anteriorly. Then comes the iliac crest and then posterior superior iliac spine. Now there is a common thing that we make a mistake, that we say that Taffirs line is line joining ASIS. No, if it is ASIS, it will go very low. It is line joining the highest points of iliac crest, which corresponds to intervertebral level between L4, L5, or if you feel body at that point, then it is body of L4. Okay? And this is the point where it is safest to put the needle for spinal anesthesia, because the ending of spinal cord is upper border of L1 in adult and lower border of L1 in adult and upper border of L3 in pediatric patients. So better to go below L3. Again, core pharmacology question. Benzodiazepine antagonist, but since we use benzodiazepines for pre-medication, there is no harm in knowing it. Sugammadex, flumazanil, naloxone, atropine. Correct answer, we know flumazanil. Specific benzodiazepine receptor antagonist. So if you have a benzodiazepine toxicity or overdose, which leads to the complication. The most important complication for this is respiratory depression. Then you can use flumazenil to reverse the effect. If suppose you have opioid toxicity or overdose, you can use naloxone. If you want to reverse the effect of ROC and VEC, you can use Sugamadex. Atropine can be used as an agent of choice in OP poisoning. OP poisoning. ठीक? All right. So these were the questions that I could get. There is obviously one more question on Very's needle, but then again it becomes a core surgical question, so I'm not discussing it here. And I think there was one question on pneumoperitoneum, the gas. Again, I feel that is more of a surgical thing. I usually don't take laparoscopic surgeries, but yes, CO2 you know, and that has a lot of implications on anesthesia, especially in capnography, because CO2 pneumoperitoneum leads to hypercapnia during laparoscopic cases. So you have to increase the minute ventilation and whatever things you need to do. So this is what more or less came, and I feel the level was pretty decent. All these things we normally read when we read a subject like anesthesia. So I hope you guys made the best of what was being offered to you, and I'm always available for any doubts, clarifications if you want. And this is it from my side. If there are any doubts, then I'm waiting for 2 minutes. Otherwise, we can hang up the session. Right. So that's it from my side. If you have any doubts, you can always messenger me. You know, I'm Dr. Anshul Diwakar, and you can also follow my page, that is Anesthesia Shorts by Anshul. Okay.